Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me today for a third time on the podcast is Dr. James Dreese. Dr. Dreese is an absolute legend in the sports medicine and sports surgical field. Dr. Dreese has had a great impact on how I've been able to practice clinically, and I have nothing but great things to say about him. I've learned so much from him over the past several years. Today, Dr. Dreese and I are going to talk through a variety of different considerations as it comes to the ACL graft choice. Does it really matter that much if you choose a quad graft over a hamstring graft or over a BTB graft and so on that way? And what role does a extra-articular ligament play in the ACL reconstruction and ACL rehab process? Along the way, we also discuss a variety of other different considerations, such as graft fixation, meniscus repair in the presence of meniscus tears in conjunction with ACL tears, and so much more. Dr. Dreese, as I mentioned, is an incredible source of knowledge and insight. I highly recommend you check out his work. We've linked to all of the different ways to contact him in the description below. This episode is made possible by our sponsor for Season 5, ISOFIT. ISOFIT is my go-to way to help athletes win more and hurt less. For more on ISOFIT, you can check the description below. Enjoy. Dr. Dreese, welcome back to the podcast. I think this is your third appearance. It's so great to have you back on.
Thanks, Dan. Always a pleasure to join you. Love talking about ACL problems and sports medicine in general. So glad to be here.
Yeah, and as we were just talking about, you are kind of the guy, in my opinion, for pretty much everything related to the ACL in particular and really complex knee sports types of injuries that way. But for people who maybe don't know about you or haven't heard about your practice, would you mind filling me in a little bit about who you are and all the great things that you do?
Sure. My name is Jamie Dreese. I have now been in practice for 20 years. I went to Penn State University as an undergrad. I stayed there for medical school. I was fortunate to be able to do my orthopedic residency at the Hospital for Special Surgery in New York, and ultimately do a sports medicine fellowship at the University of Pittsburgh for a year. I was in practice in Charlotte for 2 years, and I've been in Baltimore now for the past 18 years. MedStar Hospital, MedStar Sports Medicine Institute. I practice primarily at Union Memorial Hospital and primarily take care of knee and shoulder injuries. I don't do any joint replacement, so everything I do is focused on these ligamentous or meniscal, articular cartilage, arthroscopic procedures. I also do a fair number of proximal hamstring repairs. So that makes up the vast majority of my practice.
Yeah, no, that's incredible. And I think I remember reading a stat sometime that you're doing like over 100 ACLs a year, and you've been in practice for almost 20 years now, you said. So this is something that you've seen quite a bit of cases about. And as you were just talking about, before we jumped on the recording, everyone presents a little bit differently. And I think a lot of times we look for the one answer, the one solution to the problem, when in reality, every patient and every case is going to present a little bit differently to us. The mechanism might be different, their clinical presentation might be different, their goals might be different. So I think that when it comes to this topic of the ACL, we have to have different options or solutions to the problem of an ACL rupture or an ACL tear that way, as opposed to just trying to fit everything into a one-size-fits-all approach.
Yeah, absolutely. I mean, I think ACL injuries are really variable between different injuries. And in as much as it has to do with the ACL injury, it has to do with the other concomitant injuries, which is typically meniscal tears on the medial or lateral side, sometimes cartilage injuries, sometimes other ligamentous injuries. And the way in which that affects treatment is pretty substantial. And it leads to what we were talking about earlier, which is that there's not always the same answer isn't always the right answer for everyone. There can be differences in treatment based on the injury pattern, based on the goals of the patient, based on the timeline. There's a lot of different factors that can figure into that. So I think it's always good to have a lot of different options available to us, and ultimately to make a really informed decision with patients about what's best for them. Because as I'm sure we'll talk about with graft choices, there are things that we have to accept that are risks associated with different graft choices that vary. And some of those might be more acceptable than others to different patients. So it's just a really important conversation to have with informed consent with the patient before we move forward.
Yeah, I completely agree. And you're right. I feel like a lot of times patients are presented with so many different graft choices by surgeons, which it's great to know that they have options. But you're right. Each one comes with its own set of pros and cons to kind of weigh and consider that way. And I think, like we talked about, that choice has to be made by the patient and their family, and understand that, one graft might not be the best for, those specific goals, while another one might be a little bit more superior towards what they want to get back to, but also understanding that, what a physical therapist might see clinically as far as outcomes from that graft or what they've seen in the past, in addition to the surgeon's own comfort level doing that graft as well, I think all plays into it as well. So, to give a just brief example of that, I had one patient ask me about a hamstring graft at one point, and she was like, "Yeah, my surgeon said he hasn't done one in like 5 years. Should I still ask him for that?" And I was like, "That's a conversation between you and your surgeon, but if that's really how you want to go through with it, going with something that someone hasn't done in 5 years might not be the best approach." And I think that that should be a conversation that you have in the sense of maybe there's another option that your surgeon is actually doing regularly, like a quad graft or a BTB graft or whatever that way. And understanding that the surgeon comfort and the surgeon experience that way plays just as big of a role into this, in my opinion, as does, selecting the right graft for the right patient.
I couldn't agree more. I mean, I think the best advice that I give to patients who ultimately are seeking care elsewhere is with regard to that, to choose the option that your treating surgeon is most comfortable and most experienced with. I don't think you want to ask someone to use a graft or perform a technique that they simply are not comfortable with or don't have a lot of experience with. Experience is important when it comes to outcomes here. And I couldn't agree more that I think going with an option that the treating physician is very comfortable with is generally the right choice for patients, and I think is the best advice that I can give to them in terms of how to make decisions and moving forward.
On that note as well, I believe from what I've seen from you in the past and what we've talked about, the BTB graft and the hamstring graft are your normal two go-tos. Is that correct?
I use those the most. I would say I probably do about half of each. I've done some quad tendon grafts. So I've used a little bit of everything, but I tend to think about this as either a bone to bone healing model with a patellar tendon graft or a soft tissue to bone healing model with the hamstring graft, which is the same healing concepts as you have with a quad tendon graft. So those are generally the concepts, and those are the grafts that I would typically recommend to patients.
Yeah, and I think those are the three that I definitely hear about the most: BTB, quad, and hamstring. But there are other things that exist out there. On the BTB graft in particular, I feel like that is the one that I hear the most about. And you're right, that stands for bone tendon bone or bone to bone, whatever you want to call it that way. And I think that this is still, largely considered the gold standard graft for a lot of people, in the sense that it's the strongest from a tensile standpoint. And that bone plug on either end of it also seems to, from the research standpoint, suggest some better integration into the bone itself and better healing. Is that correct?
But yeah, bone patellar tendon bone. I mean, I think there's a couple of concepts with grafts that are important to understand. So ligaments, essentially, the ACL, anterior cruciate ligament, attaches the femur to the tibia. That's what ligaments do. They attach bone to bone. Whereas the quad tendon or hamstring tendon is essentially the insertion of muscle and the transition from muscle to bone. That means that histologically, they have some different features, and biomechanically, they behave a little bit differently. Interestingly enough, the patellar tendon is really the patellar ligament. It attaches the patella to the tibia. So histologically, it behaves and looks more like a ligament than it does like a tendon, which is an interesting caveat for why historically we have thought that patellar tendon grafts have lower failure rates. A lot of outcome studies have shown that when used in isolation. Now, I think the other important caveat is that the big evolutionary change of these lateral capsular ligamentous procedures has changed those outcomes to a large extent. And we can talk about some of the studies that have looked at that. But in terms of just simply comparing graft to graft with the same isolated ACL reconstruction, the patellar tendon grafts have had lower re-injury rates. And in part, that might be because of the fact that it is more structurally like a ligament and less like a tendon. So it has an ability to resist forces in more the way that a normal ligament would have than a tendon necessarily has. But there's a different healing model to the bone. A bone patellar tendon bone graft heals bone to bone in more of a fracture model. It's more reliable. Within 6 weeks, you essentially have bridging bone across that gap, and the graft itself is actually quite stable. Soft tissue grafts take much longer. They heal via soft tissue to bone, via Sharpie-like fibers, or sometimes with just fibrous ingrowth, and that takes significantly longer. What's been estimated to be 10 to 12 weeks in many biomechanical and histological studies. So it's a different healing model, and that may in part also be related to why we see higher failure rates with that soft tissue to bone healing model. That has all changed, though, with the concept of these lateral extra-articular ligamentous procedures for sure.
Yeah, no, it's so interesting that you bring up the histological element to this, because I think in conversations like this, that's often forgotten about, right? We're using different tissue in place of what was originally there. So understanding that that tissue might have different, underlying factors such as, say, protein synthesis rate, for example, and understanding that those kind of things do play into the healing and loading effects of that tissue, I think is often forgotten about that way. In my opinion, if we're impacting extensor mechanism in any means, aka quad graft or BTB or whatever, there's going to likely be some kind of change to the way the kneecap moves and functions and operates temporarily in any of them. The quad muscle is going to function a little bit differently until it heals that way. So I guess, on that concept of the BTB graft, I don't really see that, impact on patellar kinematics, so to speak, as like a primary cause for concern, or in someone who maybe had past history of patellofemoral pain? Or is that something that might steer you away from using a BTB graft in someone?
Those are all some of the considerations. Quite honestly, any autograft is going to have some disadvantages and risks associated with where the harvest has come from. So for patellar tendon grafts, obviously the sensory nerves in the front of the knee can be damaged by the approach. So that sense of altered sensation, numbness, or just intolerance to kneeling can be significantly higher with patellar tendon grafts. We're violating the central third of the tendon, so a lot of scar tissue is going to form in that location. It forms behind the tendon, which is why these grafts have a higher propensity for causing stiffness afterwards and may require more treatment to remove scar tissue and try to regain range of motion. It's certainly been associated with higher risks of kneecap arthritis down the road. We've seen that play out as well. And then, of course, there's the knee extension strength component to it and how long it simply takes to regain knee extension strength. So I think of all those things as essentially being secondary to the individual nature of the graft and the way in which the harvest of the graft affects the extensor mechanism. No different than the quad tendon affecting that, and no different than the hamstring tendon affecting knee flexion strength potentially. So those all come with some risks. The major benefit of the hamstring tendon graft is that you avoid the extensor mechanism, obviously. You tend to have a lower risk of the kneeling difficulty and some of the altered sensation in the front of the knee, which if you work as a carpenter or a plumber or you work on your knees is a big deal. And sometimes even for recreational athletes, it can be a big deal. So those all have impact on risks afterwards. And that's all part of the discussion beforehand about what graft makes the most sense and which risks we're most willing to accept.
When you say hamstring graft too, what muscle do you, or tendon, I should say, do you specifically harvest for a hamstring graft in your practice?
So the hamstring grafts come from the inner side of the knee directly below the tibial tubercle. That's the gracilis and the semitendinosus. So it's really two of the powerful knee flexors. The biceps femoris is lateral, the semimembranosus is posterior. So those two are not affected by it. but the two tendons on the inner side, the gracilis and semitendinosus, are harvested. And even though you're left with powerful flexors of the knee, there are some studies that show that in some patients, particularly at higher flexion angles, there may be some loss of knee flexion strength that they have to continue to work on in moving forward. That's really the bigger downside with that. And of course, we talked about the outcome studies that historically, with isolated ACL reconstruction, have shown slightly higher re-rupture rates with soft tissue grafts like the hamstring graft, particularly in the youngest, most at-risk patients. In older patients, the differences between failure rates become significantly less, but certainly in younger patients, we have seen historically in a number of studies higher rates. What we've also seen, though, more recently is that with these lateral procedures, we can mitigate that risk greatly.
Definitely.
And as it turns out, that procedure on the outside of the knee proves to be probably a more important decision than what type of graft we use.
Yeah, that's such an interesting concept because you're right. A lot of people do get caught up in the conversation of like, well, I hear this one's better than that one. But as you mentioned, that procedure on the outside of the knee, or the ALL, I believe it's called, extra-articular ligament reconstruction, that way, can certainly add a lot of rotational stability to the knee. And I believe that's the primary failure rate for most tendon grafts that way, is more of the rotational component of the knee injury. And it's interesting that you brought up on the hamstring grafts, both of those muscles, the semi-T and the gracilis, also rotate the knee. So understanding that as we start to pull a tendon to reconstruct an ACL, that those muscles also impact knee rotation, doing additional things to help restore rotary stability to the knee becomes absolutely essential. And I know that this is something that you've done a lot in your practice, is that IT band tenodesis type of procedure that way, where I believe you kind of reroute a piece of the IT band extra-articularly to a position on the tibia to help restore additional rotary stability to the knee.
Yeah. So, I mean, just conceptually speaking, first of all, historically, we've always regarded the primary function of the ACL and blocking the anterior tibial translation, the tibia translating anteriorly on the femur, and that is one of its roles. But as it turns out, that's really not functionally its major role. Its major role is to block internal rotation of the tibia relative to the femur. And what we've always seen historically is that in many patients historically with conventional ACL reconstruction, the anterior translation of the tibia would be protected and restored with reconstruction. But rotationally, these knees were still rotating in excessive means internally, particularly when compared to the other side. What we saw historically with that now and looking back on it is that that led to higher rates of secondary injury, either to re-rupturing the ACL graft or to tearing the meniscus, primarily the medial meniscus, because the rotational forces were being transmitted to the medial meniscus, which is the secondary stabilizer for the ACL. And ultimately, the medial meniscus failed because it was being exposed to these excessive rotatory forces. That led to more recently, and actually it's not that recent, it's been 10, 15 years where this study has been conducted into looking at rotationally what's been damaged that's causing that rotational instability. Is it simply the ACL, or are there other injuries that happen when you tear your ACL? We know when you tear your ACL, there's a pivot shift that occurs inside the knee, and we see a classic bone bruise pattern on the outside of the knee. The appearance of that led to the investigation into, well, has something been damaged that's allowed that bone bruise pattern to occur? Because the bone bruises are in different spots on the femur and tibia that suggests that the tibia has excessively translated and rotated. And the question of whether that simply was the result of the ACL being torn or other structures on the outside of the knee being injured has been certainly a thought-provoking question. What a number of MRI studies have shown is that in a significant number of patients in whom ACL tears occur, there's damage to the capsular and ligamentous structures on the outside of the knee, which more or less insert directly adjacent to the lateral collateral ligament on the outside of the knee. So we've been able to see in MRI studies where damage to that occurs, and now there's good evidence that shows the pivot shift is really probably more a result of that injury on the outside, in addition to the ACL injury that happens when you get that. So it led to a lot of initially biomechanical work, cadaveric work in the lab and now a lot of clinical studies that have looked at different ways to try to restore the integrity of rotational stability by doing a procedure on the outside of the knee. That procedure can take the form of either an anterolateral ligament reconstruction, where basically the ligament is reconstructed from right next to where the iliotibial band attaches on the tibia up to a spot adjacent to the lateral collateral ligament on the femur. Or the second technique is what you had mentioned, which is taking a central slip of the iliotibial band and rerouting it from its native insertion on the tibia, keeping that intact, and then rerouting the upper part of it to that same point on the outside of the knee adjacent to the lateral collateral ligament insertion. And what we've seen, certainly in my practice, as well as a number now, dozens and dozens of domestic and international studies have shown that that procedure can restore more normal rotational stability to the knee. And most studies show that reductions of more than 50% in both re-rupture of the ACL graft as well as further tearing of the medial meniscus. So it's really had an evolutionary effect on the outcomes of ACL reconstruction, not just in terms of re-injury, but also in terms of function and rotational stability of the knee, which is such an important part of return to play, risk of re-injury, and outcomes in general. So I really think that it has had a really monumental effect on outcomes here, and has been probably the biggest advancement in ACL surgery since my time in practice. And that would include differences in technique with how we drill the femoral tunnel, better understanding of the native anatomy of the ACL. But I think in terms of outcome, certainly this procedure on the outside of the knee has had a bigger impact on outcomes than anything else we've seen in my career.
Now, when you reference these studies on outcomes that way, does that also apply to injury to the contralateral lower extremity as well? Because I know that's something that often gets debated in the sense of the re-injury rate on the other leg is also often higher than most people would like to see that way. So if we do this extra-articular ligament reconstruction on the leg that we're getting surgery for, that does not change our likelihood of tearing our ACL and our other leg at all, correct?
Right. I mean, I think there's different concepts about why the risk of ACL injury in the other knee is as high as it is. That risk is highest in the youngest, highest risk populations. And in large part, I think that a big part of that is structural. There are certain anatomic factors in knees that put them at risk. There's a reason that some knees with these non-contact mechanisms have ACL tears and other knees don't. Those knees are going to be at substantially higher risk for injuring the ACL in their other uninjured knee when looking at longer term studies for sure. But then the question becomes, is there a sense of a conditioning or deconditioning of the other knee that occurs from the downtime following ACL surgery on the other knee that puts them at risk with initial return to play? Many of those contralateral knee injuries occur with initial return to play or in that early phase of return to play. So there may be a deconditioning component to that as well, which inherently makes sense. But undoubtedly, there are anatomic factors that put those knees at higher risk than other knees may have. We certainly know that there just simply are some knees that seem to be at higher risk. And when we see an ACL injury in one knee, we certainly know that other knee is at high risk. And we want to fully engage in all the good prevention programs that exist in an effort to try to limit the risk of injury to the other knee.
Yeah, no, I think that's such a great point. You're right. There's so many different factors and variables that go into this that way. And, I think the other piece that goes into that factors, variables, consideration side as well is in the rare case, you get a revision case as well. And I've seen a couple clinically now where, they tore their ACL and then they retore the same ACL again. I think that extra-articular ligament reconstruction conversation becomes even more important because it's a repeat injury now. It's bad enough to have this happen once. It's exponentially worse to have it happen a second time. If it happens a third time, that could potentially be career ending or life altering for people that way to have to go through this for a third time. So I certainly think making sure we do anything and everything we can to make sure that doesn't happen a third time. If it's already happened a second time, the extra-articular ligament reconstruction becomes a key part of that conversation.
Yeah, I think that's a great point, Dan. I think just you have to be pragmatic about these things. I think when you tear your ACL the first time, we have a certain mindset. When you tear your ACL the second time, we have to stop and think, what is it that happened the second time? And certainly, if we simply repeat what we did the first time, we're highly likely to fail the second time, which brings into play many of the concepts that we've learned. It has to do with that ligamentous structure on the outside of the knee that we just talked about, and why that's so important in trying to constrain rotational forces, and also just in terms of trying to limit the risk of re-injury with that. The other concept that has very much come to light in the last 5 or so years is the concept of tibial slope. So we know that in patients in whom the tibia has more of a posterior slope, there's an additive anterior translational force on the tibia, which increases the risk of further injury to the ACL. That's been shown in any of a number of studies. So in those patients in whom a second or a third ACL tear has occurred, it's really important to do a more complete evaluation of that tibial slope in an effort to try to determine whether that is one of the risk factors that has led to the re-injury. And if so, to address that by decreasing the posterior tibial slope. That has received a lot of attention, particularly in Europe and throughout Asia, and now more so domestically in the US as well. But that clearly is a well-defined risk factor. And for patients in whom revision ACL reconstruction is being considered, evaluation of that is an important part of that determination of what the right path forward is.
And the procedure to address the posterior tibial slope would be a osteotomy type of procedure, I believe, correct?
Correct. It's an osteotomy procedure for increased posterior slope to decrease the slope, which helps to decrease the anterior translation of the tibia relative to the femur. And that's been shown to substantially reduce the likelihood of further ACL graft injury in patients in whom revision reconstruction has been considered. It really is not a primary consideration for primary ACL reconstruction at this time, although we'll see how that evolves over time. I think even those lateral capsular procedures a couple of years ago were considered to be more appropriate in revision situations, but the majority of patients with ACL primary reconstruction undergo that lateral procedure now as well. It really has become more the standard of care, and who knows where we'll go with the tibial slope. It's all guided by clinical outcome studies, and I think those will ultimately determine whether or not utilization of that in the initial ACL surgery becomes deemed to be more appropriate.
Completely agree. And, it's interesting. You brought up the outcome studies and you mentioned that you trained at Pittsburgh for a given time. And I think anytime people hear Pittsburgh and the word ACL together, the name Freddie Fu comes to mind. And I remember at one point that the double bundle procedure was very highly touted coming out of Pittsburgh. And it's interesting because I don't see nearly as many double bundle grafts in today's day and age. And you mentioned before that you feel like when you do tendon grafts that way, the majority of them or all of them are single bundle, I'm assuming, and the double bundle procedure is kind of faded away for the majority of the cases that you work with that way?
Yeah, I mean, good question. I mean, first and foremost, let me just say that Freddie Fu was one of the most influential mentors of my career, and just an iconic figure in the history of sports medicine. I can't say enough good things about that man and about his contributions to science and orthopedic sports medicine. He truly was a legendary figure in sports medicine. And I'm sad to not have him with us any longer. With respect to the double bundle concept, I mean, it goes back to the anatomy. So Freddie did these studies in the early 2000s looking at the anatomy of the ACL and made a determination that we clearly see two different bundles in the ACL, an anteromedial bundle that's more vertical and a posterolateral bundle that attaches more laterally and is more horizontally oriented. And that really led to a lot of conversation that goes back to what we were talking about early, which was this persistent rotatory instability that is present with many of these single bundle reconstructions, which are essentially anteromedial bundle reconstructions. So the concept behind it was to better control that rotational instability of the knee. That was the concept behind the double bundle procedure. And we actually had a previous experience of that with the PCL. And what both of them showed was that in the laboratory, they seemed to have some some minimal effect on that, but clinically, we just haven't seen it play out as much. The reason that the lateral augmentation procedures, the ALL reconstruction and the LET came to be was essentially to try to correct the same deficiency that the double bundle reconstruction was designed to do. We've just seen clinically in a number of studies now that the lateral augmentation procedure seems to do a better job of it and have better success rates in doing so. And I think is largely the result of the fact that there is a capsular injury on the lateral side of the knee when you get that pivot shift, and even a double bundle reconstruction doesn't address that. But they really were designed to more or less directed towards correcting the same rotational instability between the anterolateral ligament and LET reconstruction and the double bundle reconstruction. So it was the same deficiency in single bundle ACL reconstruction that led to the development of both of those techniques.
Right. So on the LAT, again, it's the same concept, the same consideration in the sense that your single bundle graft might be a little bit more vertically oriented and the IT band tenodesis might be a little bit more horizontally oriented. It's just now that secondary stabilizer, if you want to call it that, is extra-articular as opposed to being intra-articular in nature.
Yeah, it serves as a check rein to internal rotation of the tibia. It blocks that excessive internal rotation. It's actually, the iliotibial band has been used by the pediatric orthopedists in the skeletal immature population for decades. They've used it for a long time. And many of them have been able to show very high success rates, even with primary utilizing that in ACL reconstruction, where the iliotibial band would be wrapped around the back of the femur and then brought through the knee to avoid the growth plates and avoid growth arrest from that standpoint. But a number of them have shown that those patients did well enough with that they ultimately didn't need to have a different ACL reconstruction once they had completed growth. So there's clearly something to the function on the lateral side of the knee with that. It's really just been sort of applied more broadly to ACL reconstruction over the last 5 years, 7 years, maybe. And now a number of studies have shown its benefits. It's really not open to debate anymore as to whether or not it's beneficial. It's more now a matter of trying to determine whether one versus the other of those lateral procedures may be more beneficial. And that's still somewhat open to debate.
Yeah, no, that's an interesting point. And it's interesting going back to what you mentioned earlier about the histology, histologically or just in general, biologically, it's so interesting to look at the strength of the iliotibial band and just how strong this structure is, because I think a lot of times clinicians get scripts where it says to stretch the IT band, and then you look at how much force is needed to stretch it, and it's like no human is able to exert that level of force to actually stretch this structure. And if we can't stretch it ourselves from a rehab standpoint and the forces that we display that way, then to me, it certainly seems like it's a strong, solid, well-built structure that makes it perfect for something like this that way. And, I know you mentioned a few different times about, the cadaver grafts that way and those kind of falling to the wayside. And I think that concept of having strong tissue to, choose from for reconstruction, as opposed to having tissue that might, from a research standpoint, be slightly weaker in tensile strength, that way makes, another important conversation point. And even the conversation around, do you do a potential cadaver graft with a extra-articular ligament reconstruction in someone who might be of a, slightly higher age that way? Maybe you don't want to disrupt soft tissue, whether it's a quad or a hamstring graft, or maybe you don't want to do a BTB graft, because you're right, maybe they are that 40 to 50-year-old carpenter who spends a lot of time on their knees, like you referenced earlier that way. And I think that conversation of possible cadaver graft plus ALL enters the chat more than either one alone, I guess I'll say.
Yeah, that raises a number of interesting points. For starters, we know that whatever you want to call it, donor tissue, allograft, cadaveric tissue, that tissue is frozen and then is thawed in the operating room and can be used for different purposes. We know that when it's used to reconstruct a ligament in the joint itself, what we call intra-articular, there's a higher rate of failure. And in the younger, highest risk populations, it's somewhere around 4 to 5 times higher rate of failure, according to most studies. So it's a substantially higher rate of failure. What we don't know is whether when we use it extra-articularly, so for instance, for this anterolateral ligament reconstruction, lateral collateral ligament reconstruction, those types of reconstructions outside the joint, is the failure rate higher? And if so, how much higher? Inherently, it makes sense to me that the failure rate's going to be higher. It's going to be reflective, though, of the force on the graft and other factors as well. So it may be different in different locations, but certainly it's been used, the cadaveric tissue has been used more extensively outside the joint in younger populations, and some authors have reported successful results with that. I think it's the use inside the joint that really clearly has been shown to have dramatically higher failure rates for sure.
Definitely. And the other piece I guess I want to bring up as well is I get questions from people different times as they're reading online and that sort of thing about, hey, do you know how my surgeon is going to fixate the graft in my knee? Are they going to use screws, or how are they going to hold it in place? And a lot of times I haven't seen a whole lot of variability in fixation type having an impact on outcomes clinically. Have you seen anything different as far as what is used surgically to actually hold the graft in place? And does that really make any substantial contribution to the outcome that way? Or is it more about the art of actually tensing the graft correctly and getting it in the position that you would like?
Well, I mean, those are all important factors. I would just start with patellar tendon grafts. So historically, patellar tendon grafts have been fixed with interference screws that basically compress the bony graft, the bony portion of the graft against the native bone. And it's with compression that bone heals to bone. So that leads to a very effective healing model. More recently, there's been some attention on using what we call suspensory fixation, or a loop and button configuration, to more or less hold a graft within the tunnel, in the hope that without that same compression, the bone will heal to the surrounding bone. And I think for patellar tendon grafts, that has been shown to have similar outcome success rates as the compression has. Now, soft tissue to bone is a little bit of a different issue. So we know that in order to really get a soft tissue graft to heal the bone, we have to form these Sharpie-like fibers that we call them, which are these mineralized transitional fibers between the soft tissue graft and the bone. Those form primarily in compression. So some type of fixation that compresses the graft against the bone leads to the highest rate of those. But many of the soft tissue grafts are fixed with suspensory fixation. And the question with that is whether or not we see higher failure rates directly as a result of a suspensory form of fixation. That hasn't definitively been proven, but essentially with that suspensory fixation, we're more or less holding the graft in place, and the loop and button configuration are more or less keeping the graft in position with it. So we really don't have definitive answers to that, but there are different ways to fix grafts. I personally believe that compression of soft tissue to bone is an important part of healing, but I do think that concepts such as this fall by the wayside a little bit in terms of their significance when you compare it to some of the other things that we were just discussing with these lateral procedures. And the other thing that ultimately, as you know, the other thing that leads to success versus failure in many of these patients is the ability to preserve their meniscus. Removal of significant parts of the meniscus is sometimes not avoidable, but certainly we try to preserve it whenever possible. But we know that higher degrees of meniscal insufficiency and absence of segments of the meniscus can lead to higher translational forces on the knee, higher risk of failure of the graft, higher risk of osteoarthritis long term, and just poor outcomes, poor return to play numbers, and general outcomes that are not as good as when we're able to preserve the meniscus itself.
Yeah, no, definitely. And on that point on the meniscus as well, I know when we chatted with Dr. Kane earlier about the meniscus, he brought up the meniscal root tear in particular. And I think he referenced, I want to say the stat was 1 in 7 ACL ruptures also have a meniscal root tear associated with them, or maybe that number's slightly lower or slightly higher. But it's the concept of the meniscus tissue is quite frequently injured, and maybe it sees us, but if we don't look, maybe we don't see it. And making sure that those things are addressed has to be a high priority, because as you referenced, from the preservation standpoint, but also the restoration of function, reduction of pain and symptoms, and so on that way. And I believe if that is the case where there is a root tear as well, typically the tunnel for the root tear fixation is done separate from the ACL tunnel.
Right. So, recognition of meniscal root tears has really, it's been the last, I would say 15 years at least, that has really come to light regarding the significance of those injuries. Most of the root tears with acute ACL tears are the lateral meniscus, and there are a significant number of people that tear their ACL that either have a tear at the insertion or directly adjacent to it. And that's the result of that excessive rotational force that makes the pivot shift bone bruise pattern, and that really overloads the insertion of the lateral meniscus. Now, the other thing, though, that we also see are some of these medial meniscal root tears, oftentimes in more chronic ACL insufficiency patients or in the multiligamentous knee pattern. The medial root can be torn. So it is important to recognize both of those. The medial meniscal root tears are much more readily recognized now on MRI. I think 10 years ago or so, they weren't as readily recognized in terms of the significance of them, but that has increased a lot. The lateral root tears prove to be more difficult, even on MRI, to diagnose. We've done studies on these that showed that they're frequently missed. They may not be picked up until the time of surgery. They just aren't as obvious on MRI. And it's not infrequent that they get missed by the reporting radiologist or even an experienced orthopedist. So there just has to be a high index of suspicion for those lateral root injuries. And when they're present, they need to be repaired because they are important and they have an impact on outcome for sure.
Yeah, essentially, when the root is torn, the meniscus is essentially rendered insufficient, I believe.
Correct. So the circumferential fibers that make up the meniscus have an insertion both in the back, which is adjacent to more or less the PCL, and in the front, which is more or less adjacent to the ACL. It's typically the posterior insertions that tear because of the way in which the tibia translates anteriorly. So it's going to put the posterior structures under more strain, and that's how those injuries occur. But it's the insertion points in the back, and when you tear those, biomechanical and clinical studies have shown that it basically renders the meniscus completely incompetent, which leads to, particularly on the medial side of the knee, leads to rapid progression of arthritic change in a lot of patients. So it's important to recognize these both in the ACL population and in the general population, but it's just, from a technique standpoint and technically, it's a little bit more difficult with ACL reconstruction because we're trying to do so many things at the same time. So it requires some, a skill set that allows you to be able to alter things and to do some things differently in order to accomplish all it is you're trying to do.
Yeah, no, definitely. And I think having a wide array of tools in your toolbox, so to speak, is certainly essential to addressing the meniscal problem, just as it is the ACL problem, like we discussed that way. And on that note, on menisci for a second there, it's interesting to look at the repair techniques that way. When we chatted with Dr. Kane, he made a strong case for having the inside out technique in your toolbox to repair these from a surgical standpoint. And he said, yes, it does take a little bit longer and there is additional tissue dissection and your surgical skills need to be competent enough because these are some, vulnerable areas that you have to perform the dissection in, but taking the time and doing it right and having a stronger fixation or a stronger suturing, I guess I'll call it, of the meniscus tissue to him was certainly something he felt was more important than just getting in and out quickly and doing a repair that could be potentially better if a different technique was utilized.
I couldn't agree more. I mean, Lyle has a lot of wisdom, and I think he's spot on with those assessments. Certainly, the inside out repair, which is more than, I would say, 95% of what I do for those types of meniscal tears. It does require more time. It does require an extra approach, more dissection. But I think for those of us who are very experienced at doing it, we strongly believe that we can get a more stout repair that's less likely to have further problem with that than we can with some of the all inside techniques. There are some locations of the meniscus where the inside out repair proves to be more difficult, but for the majority of tears that are not at the root insertion itself, the inside out repair is really very facile and gives you the ability to be able to get as stout a repair as possible. One of the factors that that figures into success there too is just the quality of the meniscal tissue. And unfortunately, sometimes for these more chronic tears, even everything we have to throw at it in terms of the inside out repair and sutures sometimes may not lead to success. But I clearly and firmly believe that the inside out repair gives us the best chance for success in the majority of those instances. But it does take more time. It's technically more demanding. You need some good help to be able to do it. But long term, I think for my patients, I always feel it's in their best interest to do that. So that's typically the approach that we use.
I love that you brought up the point of good help there, because you're right. You have to trust whoever's holding the retractor spoon in this case pretty strongly.
You do. It's a teamwork approach. You need to have good, skilled assistants with you, which is important. And everybody has to be on the same page. So there's a lot. Experience has a lot to do with the success with that and making good decisions. But in terms of what gives patients the best chance for success, I think having a good team in the room with you is an important part of that. And something that we always strive to have available.
Yeah, no, I completely agree. And just to kind of bring this all back together and go back to, this concept of, patient comes to you and asks what ACL graft I should get. From what we've talked about so far, it sounds like the graft choice, each one has its pros and cons, but the graft choice itself seems to matter a little bit less than the addition of the extra-articular ligament does. And the ALL, or extra-articular ligament in this case, really needs to have a key point and a hallmark spot within the conversation of what graft we should get. And the other piece to the puzzle as well is making sure all the other factors that go into the ACL injury in the first place are addressed, whether that's making sure that you repair the meniscal tissue correctly, identify other injuries, whether it's a meniscal root, other ligamentous structures, cartilage structures, or so on that way as well.
Yeah, let me just highlight a couple of really important studies, Dan, that you alluded to a little bit, but I think deserve special mention here. So there have now been a number of studies that have shown the importance of that procedure on the outside of the knee. And as I was alluding to earlier, prove that procedure, in my mind, and in the conclusions of these studies, that procedure is more important than whether you use a hamstring graft or a patellar tendon graft. So several of the big studies have shown that in comparing patellar tendon grafts to a hamstring graft with a lateral procedure, that the hamstring graft with the lateral procedure had a 3 times lower rate of re-injury than the patellar tendon graft, which really contradicts everything historically that we've thought, which were that these hamstring grafts had, somewhere around a 25 to maybe 50% higher re-injury rate. Well, as it turns out, that procedure on the outside not only negates that higher risk, but it actually dramatically reduces the risk to the point that the patellar tendon graft saw a 3 times higher rate of re-injury. My point with that is that the procedure on the outside of the knee is the most important part. I'm not suggesting that that procedure doesn't come without some risk, because every procedure comes with some risk. It involves dissection of the lateral collateral ligament. So until you get a lot of experience with it, that can be demanding. And I truly believe in my patients and in a number of other patients I've seen, there's a slightly higher risk of stiffness in the knee afterwards that can increase the likelihood of potentially needing to go back and release some scar tissue in the knee to regain range of motion. In those patients, though, once they regain their range of motion, they still have a structurally much more competent knee than the patient who didn't undergo that procedure. So I still almost universally recommend it for my patients. I've certainly seen with my fellows and in seeing patients who've been treated by lots of other physicians that there's a dramatic difference in terms of the stability of the knee when that procedure on the outside of the knee is utilized. So that's why I say that I think it's the most important procedure or the most important evolutionary change in ACL reconstruction that I've seen in my career, because I think it changes outcomes in ways that we've really never seen before. But on to your second point, it is absolutely imperative to try to restore the integrity of the meniscus whenever possible, for the reasons that we talked about, not just because the meniscus is a shock absorber and it being deficient leads to higher rates of arthritis. It's also a stabilizer of the knee. And when it's not intact, you lose rotational and translational control of the knee. So the knee becomes less stable with higher risk of re-injury. And those are the reasons why preservation in all the different ways that we were talking about, whether it's a meniscal root repair or another type of meniscus tear, is such an important factor in determining success and ultimately getting the kind of outcomes that we hope to achieve with our patients.
Yeah, no, I think that's an excellent point and an excellent summary that way. And, I'm sure someone who's listening to this is going to say, I have more questions for this Dr. Dreese guy because he's super smart and he knows what he's talking about. Or maybe someone's going to say, hey, actually, I know someone who just tore their ACL and I want to make sure they go and see you. Where can they find out more about you? Where can they find your practice at? How can people contact you and get in touch with you and your team that way?
Yeah, thanks, Dan. So I am, as I said, I practice at MedStar Sports Medicine. I see patients in Ellicott City and Timonium, and most of my surgical procedures are done either at Union Memorial or up in Timonium, and now soon to be in Annapolis. So those are the primary locations that I see patients. I'm part of the Instagram generation now too, I'm glad to say. So at Sports Doc Dreese on Instagram. My office number is 410-821-5380. But I would say, I'm always happy to consult on patients. I do a lot of second opinions. And oftentimes I send people back to where they come from. But I think sometimes for people, it's just reassuring to have a second opinion that may or may not agree with what the primary opinion was that you got. But I think it's always good to have conversation and collaboration about difficult problems because many of these are not straightforward problems. There can be different opinions about them, and I think oftentimes having a bigger conversation can be beneficial for all of us. And I tell my patients all the time that it's a good idea to oftentimes get multiple opinions, but at some point you have to decide which of those opinions makes the most sense to you and makes you most comfortable. And I think it can be at least reassuring in that instance if a patient has gotten a number of opinions and feels like they have a more defined pathway for how they want to move forward. So always happy to see people for second opinions and just talk more about maybe the care they've received or the path forward from where they currently are.
Yeah, no, I think that's such an excellent point because at the end of the day, we all do what we do for the patient and we all want to act in the best interest of the patient after all. And if getting a second opinion makes the patient more comfortable and confident about how to. Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me today for a third time on the podcast is Dr. James Dreese. Dr. Dreese is an absolute legend in the sports medicine and sports surgical field. Dr. Dreese has had a great impact on how I've been able to practice clinically, and I have nothing but great things to say about him. I've learned so much from him over the past several years. Today, Dr. Dreese and I are going to talk through a variety of different considerations as it comes to the ACL graft choice. Does it really matter that much if you choose a quad graft over a hamstring graft or over a BTB graft and so on that way? And what role does a extra-articular ligament play in the ACL reconstruction and ACL rehab process? Along the way, we also discuss a variety of other different considerations, such as graft fixation, meniscus repair in the presence of meniscus tears in conjunction with ACL tears, and so much more. Dr. Dreese, as I mentioned, is an incredible source of knowledge and insight. I highly recommend you check out his work. We've linked to all of the different ways to contact him in the description below. This episode is made possible by our sponsor for Season 5, ISOFIT. ISOFIT is my go-to way to help athletes win more and hurt less. For more on ISOFIT, you can check the description below. Enjoy. Proceed forward, then I'll make that transaction every time. We'll link to all of those things below in the description, your Instagram handle, your office contact information, and so on that way. That way, if you didn't quite catch it, you can just click there. It's interesting, though. You haven't joined the TikTok generation yet?
No, I've not quite gotten that far. But I'm moving in the right direction, I think. And I love the awareness that's created with social media for many of these. I think we've seen so much more attention and more discussion in the study of these different problems that we treat from a prevention to a physical therapy to an orthopedic surgical standpoint. I mean, it just has led to so much conversation and much more awareness about these problems. I think it's good for all of us to have that kind of perspective and to have a light shined on everything that we do.
Yeah, no, definitely. I completely agree. Dr. Dreese, I really appreciate your time and all the amazing information and insights that you've been able to share with us. You are a wealth of knowledge, and I know your time is valuable, so I appreciate you spending another hour of it with us today on the podcast.
Thanks for the invitation, Dan. I love it. I love these kind of conversations. These really are very enjoyable, and look forward to doing it again.